Thank you, Sneha, and thank you, Sankeet. Good afternoon, all. So, without much delay, I would like to move on to the session. As Sangeet has already mentioned, today we will be discussing on the pain management, starting with opioids today. Next slide. So today we'll be covering the following topics: the commonly used opioids, their mechanism of action, practical aspects of opioid use, their adverse effects, and the prices of different opioids. So many of you might be familiar with this WHO analgesic ladder, which is for the pain management of patients depending upon the severity of the pain. So depending upon the severity of the pain, the WHO has suggested an analgesic ladder comprising of step 1, step 2, and step 3 analgesics. So the patients with mild pain are prescribed with step 1 analgesics, which includes non-opioids, that is NSAIDs, paracetamol, plus or minus adjuvants. And patients with mild to moderate pain are prescribed with step 2 analgesics, that includes step 1 plus or minus adjuvants. And patients with moderate to severe pain are prescribed with step 3 analgesic ladder, which include opioids for moderate to severe pain. Sorry, for step 2, it is opioids for mild to moderate pain, which includes the weaker opioids like tramadol, tapentadol, codeine. And in step 3 analgesic ladder, patients with severe pain are prescribed with opioids for moderate to severe pain, plus or minus step 1, and plus or minus adjuvants. So to understand more about the step 3 opioids, we'll start, next slide please. We'll start with the patient story. So we have a patient who was 56 years old diagnosed with carcinoma of larynx, who has reported to us with severe pain. The pain is around the neck. It is a sharp pain with no radiation, and it has a pain score of 10 on 10 since last 2 weeks, and the patient is unable to sleep. How will you manage? Can I have responses, please? You could either type on the chat box or you can unmute and speak. So we have a patient with severe pain. So we have already seen that the WHO analgesic ladder will prescribe the pain medications or analgesics based on the severity of the pain. So for this patient, the patient reports to have a pain score of 10 on 10, around the neck, very sharp pain without any radiation. And the patient the ADLs are affected, he is unable to sleep. So what can we do for the patient? How can we manage his pain?
We'll give an opioid analgesic with adjuvant because it is severe pain.
Thank you, Jagrati, for that response. Anybody else wants to add? What would be the most appropriate step 3 analgesics or step 3 opioid in this patient? So the most appropriate opioid for this patient would be morphine. And since the severity of the pain is 10 on 10, it would be ideal to go with step 3 morphine on intravenous preparation. So how do we go about the intravenous morphine titration? So suppose a patient on severe pain comes to your clinic and we are starting with the intravenous morphine titration. How do we proceed with the intravenous morphine titration? So 1 ampule of morphine contains 15 milligram of morphine. That is 1 ml contains 15 milligram of morphine. So this 1 ml is diluted with 9 ml of distilled water such that 1 ml contains 1.5 milligram of morphine. So this morphine should be given, 1 ml that contains 1.5 milligram of IV morphine should be given in every 10 minutes interval. And this should be repeated unless the patient's pain has satisfactory pain relief or the patient becomes drowsy. So the endpoint of the titration would be either the patient has satisfactory pain relief or the patient becomes drowsy. Next slide, please. So we started with intravenous morphine titration. So what would be any idea immediately if on giving intravenous morphine? Is there anything that you can anticipate when a patient is given intravenously morphine? What can happen as an immediate response to this intravenous morphine?
Morphine causes respiratory distress, so we have to monitor for it.
Okay. What could be the immediate response?
Patient feel relaxation and
Relaxation. So the immediate,
Patient got relief from pain.
yeah,
Immediate response for any NSAID. The first one is the vomiting, like nausea and all.
muscle relaxant.
yeah. So morphine, it's being a step 3 opioid, it can produce immediate emesis. So nausea and vomiting is one of the side effects that can occur immediately with the morphine administration. So we need to be cautious about that. And so before starting with the intravenous morphine titration, the patient should be given injection metoclopramide 10 milligram IV stat. Next. So the patient should be given injection metoclopramide 10 milligram IV stat, and followed by that injection morphine, as I mentioned earlier, we'll be giving 1.5, that is 1 ml morphine at every 10 minutes interval. Next. And the endpoint of this titration would be when the patient has satisfactory pain relief or the patient feels drowsy. Next. So whichever happens first would be our endpoint of titration. Next slide. So to demonstrate more on that, suppose we started a patient on IV morphine titration at 10 a.m. We'll record the pain score and also the drowsiness. If the patient is drowsy or not needs to be recorded, and also the morphine dose given should be recorded. And in every 10 minutes interval, keep recording the pain score, the drowsiness, and the dose of medication given. Suppose the patient had suppose after 3 doses, the patient's pain score, in this scenario, the patient's pain score has become 1/10, which is an endpoint for the titration. So now we are stopping with the titration. The patient has received 3 times 1.5 milligram, that is 4.5 milligram of IV morphine. And his pain score has come down to 1/10. So that indicates that this is the endpoint of titration. So now this patient has come to our OPD, but we need to send him back home. How do we do that? So we need to convert this IV morphine to oral morphine. How do we do that? Next slide, please. So in this scenario, 4.5 milligram of IV morphine has given him good pain relief. So usually when this IV morphine titration dose is converted to oral morphine, we go by 1:1 conversion rate. So the patient will be started with either 5 milligram of oral morphine every 4 hourly and can be sent home. Next slide, please. So the prescription would look like, as WHO suggests, the prescription should be by the clock, by the mouth. And the prescription would look like, usually the morphine is available as 10 milligram, 20 milligram, and 50 milligram. So if we prescribe tab morphine 10 milligram, it should be half Q4H, that is half a tablet when the patient wakes up, half at 10 a.m., another half at 2 p.m., then 6 p.m., and at bedtime, the patient should be given double dose. Why do we give double dose at bedtime?
When that time the patient is on sleep, that time we can't wake up the patient continuously. That's all.
Yes, thank you. Thank you, Pankaj, for that. Yes, we don't want to wake up the patient at 2 a.m. and give the dose again. So we provide double dose at night. And since we provide the double dose at night, this medication which enters the blood will maintain a stable blood level till 6 a.m. dose, since we are providing double dose at night. And the patient will have adequate pain relief during the night. So that is double dose will be given at night. And of course, whenever we prescribe morphine for the patient, we usually give an SOS dose of morphine. That is also the same dose will be given as SOS for the patient to take in between if the patient develops pain. Next slide, please. Suppose we saw a patient in our home care setting and we don't have an IV morphine with us. How do we go about the oral morphine titration? So in a patient who is new to opioid, it's better to start with 5 milligram of oral morphine 4th hourly. That is tab morphine 5 mg Q4H and SOS and 10 mg at night. And if the patient is already on weak opioids, start him on 10 milligram of morphine Q4H, 20 milligram at night and 10 milligram SOS dose. Next slide, please. To understand more, we'll move on to the patient story. So we had a patient who had already come to our OPD who has undergone a IV morphine titration, and he was given 4.5 milligram of IV morphine, which we converted into oral and sent home as 5 milligram Q4H. So now this Mr. X was started on 5 milligram Q4H and SOS. He had relatively pain relief for 2 weeks. He needs 3 SOS dose of morphine per day for the last 4 days. What shall we do now? So since last 4 days he was needing 3 doses of morphine per day. So how do we go about? How frequently would you give SOS dose of oral morphine? Anybody wants to comment? How can we move forward for this patient? Should we continue the patient on same dose or should we do something about the dose?
Ma'am, we have to increase the dose.
Okay, thank you. Thank you, Jagrati. But how do we increase the dose? Next slide, please. So, such scenarios, when 2 or more than 2 SOS dose of morphine is taken, we can increase the dose by 30 to 50% every 24 hours. So since the patient is currently on 5 milligram of oral morphine Q4H, we can either increase it to 7.5 milligram Q4H or to 10 milligram Q4H. So increase the dose by 30 to 50%, 30% or 50% when the patient takes more than 2 to 3 doses of rescue doses in between. Next slide, please. So how frequently would you give SOS dose of oral morphine? So in between, I always spoke about the SOS dose of morphine. I told that if there is a pain in between, we need to give the SOS dose of morphine. So how frequently can we give this SOS dose of morphine? Any comments on that?
Every 6 hours, ma'am, 4 or 6 hours in between.
In between?
4 or 6 hours.
So, Pankaj, thank you for that response. But is there any, why do you suggest 4 or 6 hours?
Because pain is continuous to the patient. That's why if the patient is we are giving the medication to patient in morning, but after the frequency of the medicine at least 6 hours. After that, maybe the patient need after 6 hours.
So the patient is currently on 5 milligram of oral morphine every 4 hourly. That is, suppose the patient has taken the morphine at 6 a.m., the next dose would come at 10 a.m. So every 4 hourly, the patient is being given morphine. But in between, the patient is having pain. That is when we make use of the SOS dose of morphine. So 10 a.m. we have given the morphine dose. Again, the patient will be given, as per the prescription, the patient will be given medicine at, can somebody tell me after 10 a.m. when will the next dose of morphine be given?
Ma'am, at 4 p.m. Sorry, at 2 p.m.
Yes, thank you, Jagrati. At 2 p.m. will be the next time for the dose. So in between, if the patient develops pain, what do we do? So the morphine, when taken orally, it takes 45 to 60 minutes, that is around 1 hour, to peak its effect in our blood. So the peak analgesic effect occurs after 1 hour of morphine intake. So SOS dose of oral morphine can be given in a gap of 1 hour. So suppose a patient was given morphine at 6 a.m. and at 7 a.m. the patient doesn't have adequate pain relief, he can be given an SOS dose. So there should be a gap of 1 hour between the two dosing. This is for the morphine to produce its peak effect. Hope I am clear.
Yes, ma'am. Thank you.
Thank you, Pankaj. Next slide, please. So now moving on to more on morphine. So as many of you might be aware, morphine, it is a naturally occurring opioid. It is extracted from the seeds of the opium Papaver somniferum. So this poppy cultivation is very common in states of India like Uttar Pradesh, Madhya Pradesh, Rajasthan. And from the seeds of this poppy plant is the morphine extracted. Next slide, please. So regarding the pharmacokinetics of morphine, we'll be discussing in detail on the absorption, distribution, metabolism, and excretion. First, on absorption. So morphine is a weak base, and when taken orally, the major part of absorption takes place in the upper part of the small intestine. And due to its hydrophilic nature, the onset of action is slow and it has longer duration of action. Next slide, please. And when administered sublingually, the absorption is very low. And the buccal and gingival administration has shown very no much evidence is there on the buccal and gingival absorption of morphine. And morphine is found to have a bitter taste. Next slide, please. So morphine undergoes first pass hepatic metabolism. So once the morphine is swallowed, it enters into the gastrointestinal tract and gets absorbed into the blood vessels. And through the portal vein circulation, it reaches the liver. So the morphine undergoes metabolism in the liver and the active metabolites are released into the systemic circulation. Next slide, please. So as I already mentioned, the metabolism of morphine takes place in the liver. Next slide, please. And mainly it happens in the liver, and a minor part also takes place in the gastrointestinal tract and the kidney. And as I already mentioned, morphine undergoes next slide. Morphine undergoes metabolism in the liver, and it forms 45 to 50% of basically morphine undergoes glucuronidation in the liver and forms its active metabolites. The active metabolites of morphine are morphine 3-glucuronide and morphine 6-glucuronide. So 5 to 10% is the morphine 6-glucuronide, and this morphine 6-glucuronide is primarily responsible for the analgesic action of morphine. And the morphine 3-glucuronide is responsible for the toxic or neurotoxic effects of morphine. So we already discussed how frequently would you give SOS dose of morphine orally when it is given, and that I have already mentioned. So once the morphine is taken into the, once the morphine is swallowed, it reaches the liver, and in the liver it undergoes glucuronidation and forms its active metabolites. And the active metabolite morphine 6-glucuronide is responsible for its analgesic action. So for this action to happen, it takes around 45 to 60 minutes. So there should be a gap of at least 1 hour between the two dosing of morphine. So the SOS dose of morphine should be given with a dose gap of 1 hour. Next slide, please. So now we are continuing with the patient story. So Mr. X pain was stabilized with 10 milligram of morphine 4 hourly. So we started him with 10 milligram, but he finds it difficult to take it every 4 hourly. He says he is willing to take it, but if you give less frequently, what can we do about it? Any comments? So we have already started him on 10 milligram of oral morphine 4 hourly, but the patient finds it difficult to take every 4 hourly. He is not reluctant to take the medication, but only the frequency is his concern. So can we do something about it?
Ma'am, we can increase the dose and decrease the frequency.
So there are some issues with that, Jagrati. Thank you for the response. But if we increase the dose, the patient can go in for toxicities. So the more ideal way of doing would be, we can go in for sustained preparations. Sustained release preparations. Next slide, please. So we have sustained release preparations of morphine available with a duration of action of 12 hours. So we have started the patient on 10 milligram of oral morphine every 4 hourly. That means 10 milligram of morphine 6 times a day. So a total of 60 milligram of oral morphine the patient is on. So we can convert this to the sustained release morphine preparation, and we can give tab morphine sustained release 30 milligram twice daily. So his frequency has been reduced. Yes. So we'll move on to the different preparations of morphine. So morphine is available as aqueous solutions. So tablets, they are available as immediate release tablets as well as controlled release tablets. And it is also available in the form of injections. So the injection that is available with us, the ampule is 1 ml that contains 15 milligram of morphine. Now moving on to so we are moving ahead with the story. Next, Mr. X, who was started on 10 milligram of morphine 4 hourly for the past 6 months, he was brought to you with excessive drowsiness. And on examination, it was found that he has a serum creatinine of 5 milligram per deciliter. Next. How do we want to proceed with this prescription? Do we want to do anything with the morphine dosage, or do we continue the same dosage? Any comments?
Ma'am, decrease the dose.
Decrease the dose. Thank you, Pankaj, for that response. But why? Why do you want to decrease the dose?
Ma'am, because ma'am, serum creatinine is increasing, so we have to focus on the excretion of morphine also. Otherwise, it will increase in body blood level.
Exactly. Thank you, Jagrati, for that. So moving on to the how is morphine excreted from the body. Next slide, please. So morphine undergoes glomerular filtration. So if in patients with renal failure, the morphine 6-glucuronide, which is primarily responsible for the analgesic action, gets accumulated. And so the clearance is decreased and the half-life is prolonged. So that means the patient, even with the same dose, there will be since the clearance is decreased, there will be more toxic effects of morphine in blood. So what we need to do is we have to increase the spacing and make the dosing either 3 times a day or reduce the dose or alternate the opioids. So this is because the excretion of morphine is primarily by the kidneys. And so in patients with renal failure, we need to ensure that either the frequency between the doses is increased or the starting dose of medication is reduced, or we can go for alternate opioids. So next, so the same Mr. X was sent home, and since his creatinine was high, we have made the tab morphine 5 milligram 8 hourly. And after 2 months, he was unable to swallow anything, including morphine, as he is terminal. What will you do now for pain relief? So the patient is having a progressive disease, and right now he is unable to swallow anything, but still in pain. What can we do for him to manage his pain?
We can go through the IV.
IV, we have to send him home. Yes, IV preparation is okay, but
We
We
can
have-
give through vials tube.
trials too. Okay.
Ma'am, sublingual.
So we already saw that sublingual absorption is not that recommendable in morphine. So the ideal would be, next slide please. So you might be able to say the answer by now. I'm showing you the routes of administering morphine. Morphine can either be administered orally, intravenous or subcutaneously, parectally, through epidural site or through intrathecally. So what would you prefer for this patient right now? A home care patient who's in home.
Ma'am, subcutaneous. Subcutaneous, ma'am, most preferable, right? If the patient is in home.
Thank you, Pankaj, for that.
Rectal.
Yes. Yes, Dr. Piyush, thank you for that response. So the ideal one would be parectal preparation. So the same oral preparation can be given parectally for the patient. So it would be more convenient for them when they find it difficult to swallow. So in our home care settings, we do give patients parectally. Subcutaneous is also possible, but this might be more convenient for the patient when it is given parectally. Next slide, please. So I'm coming back to the same question, and we have already discussed that. Next slide, please. So we can send the patient 5 milligram parectally for same preparation, 8 hours, same frequency, 8 hourly we can give the patient. Next slide, please. So now we are talking about, we have another patient scenario where Mrs. K, who is 55-year-old lady with carcinoma of the colon, has abdominal pain, continuous in nature. She was started on 10 milligram of morphine, Q4H, and she doesn't require any SOS dose of morphine, and pain is well controlled. A doctor has asked them to replace morphine with 25 microgram of fentanyl patch. Next day, the patient report to you telling that they replaced the fentanyl patch after 5 hours as she had no pain relief. What will you do? So the patient is on 10 milligram of oral morphine hourly, and she was having stable pain relief. And the doctor asked her to replace the morphine with fentanyl patch, 25 microgram of fentanyl patch. But after 5 hours, the patient had replaced the fentanyl patch as she had no pain relief. Any comments? Next slide, please. Next slide, please. Okay, so now we'll be talking about the transdermal fentanyl patch. So transdermal fentanyl patch, so how it acts is that this fentanyl patch is applied on the skin. So when a fentanyl patch is applied on the skin, it should be ensured that the skin is intact with no abrasions on the skin. So the patch should not be applied after shaving the hairs on the skin because it can produce micro abrasions on the skin and that can affect the absorption of the fentanyl. And also the temperature can also affect the absorption. So the patch should be applied on an intact skin. And what the fentanyl patch does is that it forms a subcutaneous deposition of the drug and is slowly released into the blood. And for a fentanyl patch, the effective analgesia will begin after 8 to 12 hours. So for the previous patient whom we were discussing, after 5 hours, the patient was not having adequate pain relief. So probably previous slide, please. So after 5 hours, the patient has removed the fentanyl patch, but it takes around 8 hours. It takes around 8 to 12 hours for the analgesia to happen in fentanyl patch. And usually this fentanyl patch, it lasts for 72 hours, 3 days. When a patch is placed on the skin, it lasts for 3 days. And when we say 25 microgram patch is applied, that means that 25 microgram per hour of fentanyl is being released to the body. And the most important is that it is not suitable for patients with unstable pain. As once the patch is applied, we do not have much control on the release of the medication. So usually patients with stable pain, you can convert, when you do an opioid switching, you can convert from morphine to fentanyl. Next slide, please. And regarding the preparations available for fentanyl, we have injection preparations, and we have transdermal, and also we have oral transmucosal fentanyl citrate. Fentanyl is lipophilic in nature, and since it is lipophilic, it has 100 to 150 times more potency than morphine. And the equivalent doses, 60 milligram of oral morphine in a day is equivalent to 25 microgram per hour fentanyl patch. So a patient on 10 milligram of oral morphine Q4H, that means that the patient is having a total of 60 milligram of oral morphine in 24 hours. So that patient, if the patient is having stable pain relief and you want to convert, usually fentanyl is an expensive medication. If the patient is affordable and you want an opioid switch in that patient, then the 60 milligram of patient on 60 milligram of total morphine in a day can be started on a 25 microgram of fentanyl patch. And this patch will last for 3 days. Next slide, please. Now, regarding choosing the opioid, we have Mr. P, 70-year-old man with carcinoma of lung, having a thrombing pain on the right front of the chest, which is continuous in nature, and the pain score is 5/10. He is a non-epileptic and he is on levetiracetam 500 milligram BD. How will you manage his pain? Any comments?
Ma'am, since the patient is in moderate pain, we'll go for mild opioid with adjuvant.
Yeah. And thank you, Jagrati, for that response. And which opioid do you suggest? So it is, since the pain is 5/10, you'll go with mild to moderate opioids for mild to moderate pain.
We can go for tramadol.
Tramadol. Thank you, Jagrati.
Manish is also responding tramadol.
Yeah, thank you, Manish, for that response. Anybody else wants to comment on that? So Manish and Jagrati is in favor of tramadol. Yes, according to the severity of the pain, tramadol would be the. Yes, Seema, want to say something?
But tramadol IV infusion.
Sorry.
Control. Ma'am, injection tramadol IV infusion.
IV infusion. Okay. Thank you. Thank you, Seema, for that response. So, yeah, as many of you have said, tramadol, according to the severity of the pain, tramadol would be the ideal opioid in the situation. But there is a catch here. The patient is a non-epileptic. Tramadol is an opioid which is found to reduce the seizure threshold. So tramadol, as much as possible, should be avoided in patients who are prone to develop seizures or patients on anti-epileptics. So ideal would be to go with a low dose of step 3 opioid. So morphine on a lower dose could be a better prescription for this patient than tramadol. Hope I am clear.
Yes, ma'am.
Thank you. Thank you, Seema, for that response. Next slide, please. So now moving on to opioids. Opioids, it's a general term which includes naturally occurring semi-synthetic and synthetic drugs. And they produce their effects by combining mainly with the opioid receptors. And these opioids are antagonized by naloxone. Next slide, please. So I said the opioids acts by binding with the receptors. So now what are the receptors of opioids? The receptors are mu, kappa, delta, and sigma. Sigma is not a true opioid receptor because this action is not, the action produced by sigma cannot be reversed by naloxone. So you cannot call it as an opioid, true opioid receptor. Next slide, please. So based on the receptor interaction, the opioids can be classified as agonist, antagonist, and agonist-antagonist. So we call a drug agonist because this drug binds with the receptor site and activates the receptor and increases its action. For example, morphine is a mu agonist. So when a morphine is given to a patient, this morphine binds with the mu receptor site and it increases the analgesic action. So an antagonistic drug means a drug when given, it binds with the receptor site and do not allow in the presence of the agonist drug, it will not allow the agonist drug to bind with the receptor site. So it will not allow the agonist to produce the action. So that is an antagonist. So naloxone, naltrexone are antagonist, opioid antagonist. So when naloxone is given, what happens is that it binds with the mu receptors and will not allow morphine to produce its action. So that is an antagonist. And agonist-antagonist means some drugs, they have agonistic action in some receptors and they have an antagonistic action in other receptors. So an example is pentoxazine. So it produces agonistic action in some receptors and it produces antagonistic action or it reverses the action in some receptors. Next slide, please. So now moving on to the Anybody has any idea on what are the side effects of morphine?
Respiratory distress, constipation, nausea, vomiting.
No,
Nausea, headache.
okay.
Acidity.
Thank you. Thank you, Seema, for that. So when I say side effects, that means the adverse effects, even with the therapeutic dose of the medication that produces the adverse effects. That is called side effects. The most common side effect of morphine is constipation. And then the other side effects include nausea and vomiting, sleepiness, drowsiness, tiredness, itching, dry mouth, urinary hesitancy. These are some of the side effects of morphine when it is given in the therapeutic doses. Next slide, please. And as I said, the most common side effect, around 95% of the patients on opioids are prone to develop constipation. And this is one symptom that lasts as long as the patient is on opioid. So that is why a drug that writes an opioid should not stop without prescribing a laxative. And a regular stimulant laxative is usually should be prescribed along with morphine, preferably bizacodine, because morphine itself is constipating. So a stimulant laxative can improve the motility and relieve the constipation. So along with the morphine, a stimulant laxative should be prescribed, and as long as the patient is on morphine, the stimulant laxative should also be continued. Next slide, please. As we have already mentioned, 1/3 of the patients are prone to develop nausea and vomiting. But this is a self-limiting symptom and is due to the stimulation of the chemoreceptor trigger zone. So when a patient is started on morphine, initially when we started with the IV morphine titration, I told you immediate side effect or immediate adverse effect that the patient is likely to develop is nausea and vomiting. So the patient should be, and this is due to the stimulation of the chemoreceptor trigger zone. Next slide, please. So the drugs acting on the chemoreceptor trigger zone are to be prescribed along with morphine. It could be haloperidol, metoclopramide, or domperidone. And since this is a self-limiting symptom, the drug can be continued either for 3 days. Usually we prescribe the drug metoclopramide along with morphine for the first 3 days. And then we can slowly stop that and make the drug SOS as needed. Next slide, please. So once we start a patient on morphine, the patient, around 1/3 of the patients are likely to develop drowsiness and tiredness. And this usually when we educate a patient about before starting on morphine, we need to educate the patient that the patient is likely to develop sleepiness and tiredness, which will get over with time, as this is also a self-limiting symptom. Next slide, please. So now this we were discussing with the side effects. Next, what are the toxic effects with morphine? So the adverse effect when the administered dose is higher than that is required for pain relief, or when the pain has poor response, the patient presents with toxic effects. So suppose the patient is given the opioid in doses higher than that is required for pain relief, or the patient, it is not an opioid sensitive pain and the patient is prescribed on opioid, these are situations where the patient can develop toxic effects. And how does the patient present? The patient might be delirious. He or she can develop myoclonus, drowsiness, extreme drowsiness. These are the toxic effects that can occur with morphine. And many of you were mentioning about respiratory depression. So in my next slide. So in my 10 years of experience with palliative care patients, I have never seen any cases of respiratory depression due to morphine. This is because whenever we prescribe morphine to a patient orally, we always monitor the patient and titrate the dose very slowly, monitoring the toxic effects. So if the patient is monitored and the titration is done on a slow pace and the toxic effects are properly monitored, respiratory depression is unusual. Then, when does respiratory depression occurs? It might, next slide please. It might be because there could be some other comorbidities associated with that. The patient might be having pneumonia or pulmonary embolism or cardiomyopathy, or there could be chance due to co-administration of some other benzodiazepines or other sedating drugs. Unless in such situations, otherwise, if the opioid is given orally, slowly titrating and looking for the toxic effects, it is very less likely to produce respiratory depression. Next slide, please. Does opioids cause addiction?
No, ma'am.
No. Does everybody agree with Jagriti? Manish is saying yes.
Yes, ma'am.
Okay. So we have mixture of responses.
Yes.
Okay. Next slide. So I'm just walking you through some of the literatures that says that as a result of medical use, the substance abuse of opioids is very low. So the literature does not show much evidence of substance abuse when it is used for a medical purpose. And there has always been a confusion between physical dependence and psychological dependence. And next. And always there was, like, the healthcare professionals always overestimated the risk of addiction. We were very cautious and we thought we were afraid that the patient might develop addiction. And hence we were very cautious in prescribing the opioid. So what do you mean by addiction?
Dependency, ma'am.
Dependency. So addiction or psychological dependence. So I have mentioned psychological dependence and physical dependence. So see, we have got a very long definition, which was from the American Academy of Pain Medicine, the American Pain Society, and American Society of Addiction Medicine, which states that addiction is a primary chronic neurobiologic disease with genetic, psychosocial, and environmental factors influencing its development and manifestations. Impaired control over drug use, compulsive use, continued use despite harm and craving. So this is what psychological dependence or addiction is. Next slide, please. What is physical dependence? It is a state of adaptation that is manifested by a drug class specific withdrawal syndrome. How many of you, okay, so I've got a question for you. How many of you like to have coffee in the morning? Yes, Pankaj. Must all like to have coffee. Tea, not coffee. Pooja is saying yes, ma'am. Yes. So when I say like to have, they feel that without coffee, I cannot do without coffee. So they feel like taking coffee. Every day morning, I have to have a coffee. So, okay, so Pankaj, you want to take coffee every morning. Suppose you didn't get coffee for a day, what would happen?
Nothing happened, ma'am. Just feel some.
Feels
Ma'am,
like,
just feel relaxation, just stress remove.
sorry, Seema, I couldn't hear you.
Ma'am, just like a relaxation, just
I couldn't.
Not feeling good, ma'am, actually, without
Not,
tea or coffee in morning.
not feeling good.
Pooja is saying headache.
Yes, headache. Pooja develops a headache. But see, Pankaj, you are not feeling good, but you know that your neighbor in his flat has got the coffee powder. You don't have a coffee powder today at your home and you are unable to have coffee today. But you know that your neighbor has got coffee. What would you do?
I will go for take, ma'am.
The neighbor denies. The neighbor is not letting you take.
I will try from outside, ma'am, for
Okay.
purchase.
Okay. So you are such a nice man. So, actually, so what Pankaj was telling was that he might develop headache, yes, sleepiness, as Manish said. But suppose I have a I have to drink coffee every day and not able to get coffee today because I am running in short of the coffee powder at my in my kitchen. But I know that there is a coffee powder in the neighbor's house, and if I break open that house and get the coffee powder from there, that is psychological dependence. So despite knowing that that is inappropriate, it shouldn't be done, I'll do. That is psychological dependence. This headache, sleepiness is all physical dependence. You are used to having something since long, so your body is reacting to that. So today you didn't receive it, so there will be a low mood, headache, sleepiness. So that is physical dependence. But even after knowing that this is not correct, you're trying to break open the neighbor's house and trying to get that is psychological dependence. So I hope it is clear.
Yes, ma'am.
Okay, thank you, Pankaj. So next, so here, these are the prices of the equivalent doses of morphine medications. So of the different opioids. So morphine, 5 milligram, 4th hourly. A patient on morphine, 5 milligram, 4th hourly, that is 30 milligram a day, will cost around 3.50 rupees per day. So the equipotent dose of tramadol 300 milligram of tramadol, usually the oral morphine will be 1/10. So the cost is 24 to 50 rupees per day. And fentanyl patch, as we have already discussed, 60 milligram of 60 milligram of oral morphine in 24 hours is equivalent to 25 microgram. So since this is 30 milligram, the equipotent dose would be 12.5 microgram. And see the cost, it is 250 to 400 rupees. And methadone, 5 milligram, it costs only 4.50 rupees. So this is just to give you an idea, when you make a prescription for an opioid, always understand the socioeconomic status of the patient while doing the prescription. Yes. Thank you.
So any doubt, you can use the chat box or you can unmute yourself.
No doubt, ma'am.
Ma'am, I have a doubt.
Yes.
Ma'am, like you said that any opioid does not causes cardiac depression, respiratory depression. It was based on research findings, literature finding, or books. Because books that I have read, it's clearly mentioned that it causes respiratory distress. But I haven't gone through any of the research article or any literature in recent days.
Yeah, thank you. Thank you, Jagriti, for that question. So when I say that was out of my experience as a palliative care physician, that respiratory depression is very unlikely when it is given in a titrated dose, when a trained professional when gives the or prescribes the opioid morphine in a titrated dose. So of course the side effect or the toxic effect of morphine is respiratory depression if not delivered or if not given in the appropriate manner. It can result in respiratory depression. But what I want you all to understand is that many are afraid of morphine because it can cause respiratory depression. But that is not something that, unless you are trained in how to handle that medication and how to titrate the dose and how to monitor the toxic effects, you don't have to be afraid of using morphine. That is what I really wanted to convey. Hope that answers your question, Jagriti.
Yes, ma'am. I got your point.
Thank you.
Pankaj Joshi is saying, I think, ma'am, respiration depression is just a psychological issue with many patients.
I don't think, Pankaj, because since the CNS depression can occur with the toxic doses of opioid, so respiratory depression can occur. If not used appropriately, there are chances of developing respiratory depression for sure. But with the oral morphine preparations, with the oral morphine doses, if given appropriately, it is very less likely to develop.
Actually, ma'am, I have seen in hospital, if we give any dose like morphine to any patient, that time he feel like he shows like I'm having depression, I'm difficulty in breathing. That's why I'm saying, ma'am.
So actually, I don't know whether you'll be learning, I'm not sure. In palliative care, morphine is given for respiratory distress, for breathlessness in patients with breathlessness. What morphine does is that it suppresses the respiratory drive, and that sensation, the sensation of breathlessness in the patient is decreased. So the patient will not feel less less breathless when morphine is given. The patient feels less breathless.
Okay, thank you.
So so that is given as a medication in palliative care for managing breathlessness. But it is not prescribed in the usual doses as pain medications. It should be given in a very less dose, and usually 2.5 2 times a day or 3 times a day. For chronic obstructive pulmonary disease also, we do prescribe morphine. And that is because it decreases the respiratory drive and that sensation to the patient. And the patient feels that breathlessness has reduced and he or she feels better.
Thank you, ma'am.
Any more doubts?
Is there anything else you would like to know more about or would like to discuss on today's topic?
Manish is saying small pupils, true or false, ma'am?
Manish, can you unmute and add a bit more clarity on that? Do you mean to say the toxic effects of morphine? Yeah, so morphine can cause meiosis or pinpoint pupil. That is one of the toxic effects of morphine. Yeah, that can happen. Yeah. How many of you have more opioids in your centers? You don't have morphine in your centers.
No, ma'am.
Okay.
Manish is saying only tramadol injection.
Okay. Okay. Yes. Thank you. Thank you for the responses.
So I hope the doubts has been cleared. And if any more doubts, you can use your WhatsApp chat and you can ask your query so that we will respond it back. So today we had an eminent speaker with us, Dr. Amrita. I would like to thank ma'am for such a wonderful presentation. Thank you, ma'am. So without any delay, I would like to wind up the session. And meet you in the next session. Thank you all for joining.
Thank you, Amrita ma'am, for the wonderful section, and thank you, Sister Diana, for the facilitation. Thank you all for the participation. Let's see you in the next class.
Thank you. Thank you all.
Thank you, ma'am. Thank you, sir.